Hi, I'm Gerard Finnessy from the Victorian Intensive Care Network. The following podcast was recorded at our September 2014 meeting. Is there a doctor on the plane? In part 2 of this entertaining talk, Dr Ian Hosegood, Medical Director for QANTAS Airways, talks about the current training for in-flight medical emergencies, involvement of medically qualified volunteers, advances including telemedicine, and even might touch on how to get an upgrade.
Thanks. Okay, so we saw this little diagram earlier, which is the kind of, the bow tie diagram, and I talked about the controls that we try and put in place. So I guess the way we think of it is, what can we do pre-flight, what can we do at the gate, what can we do in-flight, and post-flight is the way we think about trying to prevent and mitigate the sort of impact of in-flight medical emergencies. And so obviously, pre-flight, we try and provide information, so it's websites, even talks like tonight, hopefully making sure that people are aware of the system. We've got a travel clearance system, which we'll talk about in the middle. It's called the MEDA system, medical clearances. And then we obviously try and provide support for travellers to try and address those other issues that we talked about, physiological challenges of the flight and the airport, so wheelchairs, oxygen, stretchers on occasion, ambulance transfers, etc. At the gate itself, we train the check-in staff and the cabin crew to try and detect people who are unwell and how to act appropriately. And we also do gate clearances, so Med-Air again, or directly to us, and generally it's to our department. They'll call us saying, I've got a passenger at the gate with X, Y, Z. And the biggest issue that we face with gate clearances is the regionalised sort of network of Australia, where we've got people that come into the city for surgery or other medical issues and they want to get home straight away, and they've turned up in their hospital gown at the airport, and or with a sort of a one-line note from Surgeon X that said this guy's right to travel, or nothing at all. So we do a lot of time, spend a lot of time trying to sort out whether those people can get on board or not. Most of the time we try and get people on board whenever we can. In flight, obviously the first aid training for cabin crew. We're not going to go into that in detail today, but we do train crew in sort of advanced first aid level and CPR. We give the senior crew more extensive training. And then obviously the medical equipment that's on board, and we'll talk about that in a minute. The telemedicine service that I've already alluded to. And then post-flights, we're going to talk a bit about making sure that we reward people when they do assist in an in-flight medical emergency, so that they'll help out again next time and tell all their friends about how wonderful it is to help out on board Qantas. And then obviously sometimes we get involved in the follow-up medico-legally as well, and try and prevent something turning into a major legal event by talking to the volunteer in flight and trying to sort out issues. We quite often see people that are trying to exploit the event for their own personal gain, and quite often the testimony of the in-flight medical volunteer is very, very valuable to us. So this is just a snapshot of the website on where you can find the medical information. And we've got, the general sort of stuff about flying and health. But most importantly is, when is a medical clearance required? And here's the link to the travel clearance form. So this is a system that most larger airlines around the world will use, the MediClearance, or MEDIF, you sometimes see it referred to. And it's essentially, most airlines follow the IATA guidance. So again, I'm on the medical advisory group. That's the group that defines the guidance, and most airlines around the world try and follow the same sort of guidance for clearance. And again, today we don't have time to go into all of the various medical conditions. If you go on to and download that link, it'll actually take you through our rules and regulations around how late can you travel in pregnancy, how soon can I travel after an appendix, what about tonsillectomy, etc., etc. It goes into all of those issues. If I've had eye surgery, when can I fly? If they've injected gas into the orbit, etc., etc. So we've got all those guidance there for doctors to go and look at. And if they're not clear on the rules and they want to get someone to travel within the time frame, then they do a medical clearance. It comes to us for consideration. And essentially the way it works, so this is the form itself. We try and keep the form to as small as possible, because we know doctors don't like filling out long forms. So quite often we will follow up with a phone call and just double check or ask for a bit more information. Particularly, as you can see, the only space for diagnosis is just there. And the rest of the form goes on to ask about the various support that's required. Is there a wheelchair required? Is oxygen required? Does the person need a medical escort or not? If oxygen is required, is it 2 litres, 4 litres, etc., etc. And we do ask you to put your details down the bottom so that we can follow up. And we do about 7 to 8,000, 7 to 8,000 of these clearances each year. And in the last 5 years, we've had one of those that's actually resulted in an in-flight medical incident. So we generally find that once people have been through our clearance system, that we have pretty good outcomes because the person's been given all the appropriate support and screened to make sure they're fit to travel. Oxygen. So we're one of the few airlines that are getting less and less these days that will provide oxygen in flight. A lot of airlines these days have essentially disowned oxygen and only will either not allow it at all or will only allow portable oxygen concentrators to be used. So we obviously you can't just assume that your patient's going to be able to use the emergency supply on board. We know there's bottles on board, but that's not what it's there for. It's there for emergency. So if someone's going to need it, you need to pre-order it. We charge, I think, something like $100 to $150 for oxygen supply. That's even all the way through to London. So we're not covering costs. But essentially, it's there just as a bit of a disincentive for people just to order it, kind of just in case. We want to make sure they really want it. As I said, we allow 2 to 4 litres per minute. The systems are adjustable in between that, but we try and drive people to choose one or the other of those, and obviously continuous or intermittent. And the difference there will be that with intermittent, we'll assume oxygen is only required for 50% of the flight time. And whereas continuous, it'll be 100% of the flight time. And on both of them, we do some factoring either side in case there's a diversion or a delay or go-round. We do sometimes have a situation where the intermittent becomes continuous, and we do have to tap into the emergency supplies to get someone through the trip. At the moment, we're looking at whether we might just apply 100% across the board. Essentially, mostly it's nasal prongs. We can use a Hudson mask as well. It's got a reservoir bag. We do require 48 hours notice, and we do allow portable oxygen concentrators, and more we're trying to push people towards that as an option because it's just simpler for them, and they can also have it for their entire journey, right? Especially people that need oxygen on the ground as well. If you've got multiple sectors, you take it with you, and it's far more convenient for the passenger. And the concentrators, there's one there. It's one of the advertising guffs, I think, from AirSep. They're getting lighter, and their flow rates are getting pretty good. So they just work on a molecular sieve, the concentrators. And the other one's tracheostomy patients. So if they need oxygen, we haven't got the adapters, so they need to provide their own adapters for oxygen as well. And these other pictures are this is the classical Dixie mask for the emergency supply for passengers, and this is the quick don mask for pilots when there's a decompression. So these are very clever masks. They're two-finger operation. They're embedded in the wall of the aircraft. You pinch the 2 fingers together, you pull it out, and as you put it on your head and let go, it inflates itself around the head and brings the mask onto the face. So it's because the time of useful consciousness can be anywhere as low as 10 seconds. If you get a massive decompression at a high altitude, it needs to be a 2-finger operation so they can keep flying the aeroplane. And also, in case they pass out as they put it on their head, it sort of self-inflates and kicks in and starts supplying. So very clever stuff. Stretchers. So many of international airlines have stopped allowing stretchers on board. We still do it. We think it's a really important public interest function for the national interest. We have a lot of people being retrieved back from various locations around the world who don't have insurance or are massively underinsured, and we find it's a really important function. We also use them extensively in situations like Bali. We end up doing retrievals of some people back using QANTAS aircraft, so dedicated QANTAS flights to retrieve people from troubled areas overseas. The tsunami was another example of when QANTAS stepped in. Your typical stretcher, for those of you involved in retrieval medicine, it's not a great setup compared to a dedicated air ambulance. In some ways, there's a lot more room. You can stand up, obviously, and you're in shirt sleeves, and you can sort of work around it. But in other ways, it's very cramped. There's no stretcher bridge, and the clearance above the stretcher is not very high. So trying to fit a bridge, or particularly for neonatal cases, trying to get a humidity crib with, they're getting taller and taller as stuff gets piled on top of them these days. We struggled to do the NETS cases these days, and we're trying to figure out a way with Andrew Berry in New South Wales to start doing the NETS cases again. But it takes up 6 seats, so you pay for the 6 seats plus any escort seats as well. So you might end up paying for with a family member, a medical escort times 2 might be 9 seats. And so you are paying a fair whack. But if you compare that to the dedicated air ambulance cost, it's an absolute fraction of what it would be to get care flight or someone else to do the retrieval for you. The other option is the use, increasingly we're seeing the use of first class and J class seats. Again, we will generally, this will be limited to really compassionate cases, because we generally don't like our first class looking like that. It's not popular amongst the other passengers. But for the compassionate cases, we will do it. And it's obviously a very economical option as well. And some airlines, a couple of airlines have used these bulk crew, what they call a FAM. It's a medical module that actually gets plugged in. The A380 is the case. So it sort of folds up like that. And if you get your patient, you fold it all out and you use this as your kind of medical case, either as a dedicated air ambulance or to manage an in-flight medical incident if the person's able to be transported to that space. Equipment, it's got to be approved. We do have power available, but if it's powered, it needs to be operable by dry cell batteries, because our power supply, whilst getting better and better, is not always 100% reliable. And lithium batteries need pre-approval as well. So all the equipment, we've got long lists of all the approved equipment, but if you've got equipment that you want to carry, it's not on our list, we can pretty quickly get it approved. And we are quite often scrambling when we have to do an urgent case to try and get the bits and pieces approved for the flight. The engineers are very flexible about approving it. It's essentially a couple of aspects to it. Will it work as designed in flight, and also does it interfere with the aircraft systems? And generally, most things, we're able to get them over the line.
Sorry, Ian, so does every A380 have these medical modules?
No, it's an option. So your choice will be put your medical module in, or put in another 6 seats, and things like that. So you can imagine, what generally wins out is the 6 seats. And Lufthansa are one of the airlines that've got one of their aircraft's got an actual ICU and that they're able to install for particular missions, and it's very impressive. But it's also logistically very challenging, and revenue-wise, it doesn't return what it costs. But it is very impressive. Medair I talked about. So this is kind of the ops room for Medair. It's based in Phoenix, Arizona. It's in the basement of the Good Samaritan Hospital, quite appropriately named. And they basically tap into everything upstairs, so into the ED mostly, but then also into the obstetricians, whoever else they need to tap into in this hospital. And the technicians take the calls, and there are nurses on staff, but then the doctors will come down as soon as there's something a bit more serious going on, and they'll manage or there's several cases being run at once, and they'll manage the cases in this room. Various TV screens will show all the various cases that are on the go. It's very American, and we struggle a bit with the American aspect of Medair. And any of you who've ever spoken to them when you're in the middle of a medical flight will know, the drugs are different, and some of the way of treating things is very different. So that's one of the challenges that we face. And we would love if there was a bunch of you guys got together and developed an Australian-based telemedicine service. It'd be fantastic. So there's a good business opportunity for someone. Yeah. They do telemedicine in terms of, they used to run the Ships at Sea service, but I think CareFlight's doing that one now. But nobody's doing this type of thing. SOS actually own Medair, International SOS, and they've got a big office in Australia, but even they are not doing this type of stuff yet. But certainly we're trying to encourage a bit of competition, and Medair's got a pretty good monopoly on this space. There are a bunch of other providers. You can see I've listed there the other airlines use. Some of them have got their own in-house departments, and then there are a couple of other sort of providers, but nobody in Australia is offering this type of service at the moment. Going the wrong way. So, medically qualified volunteers. So who do we get volunteering? Most of the time it's a doctor, because generally they'll say, is there a doctor on board first? And generally there is. And I was alluding to earlier, we have about an 85% response rate when a doctor's called for. If there's no doctor, quite often we do get a paramedic or a nurse, and we generally get very good experience with paramedics in particular. Sometimes it's a better experience than many of the doctors that we get involved. Now, the picture there is just to remind us that cabin crew always used to be nurses originally when they first started up Qantas. All of the cabin crew were trained as nurses and then became flight attendants. And there was a big push when the A380 came out, because I was at Emirates at the time, we'd ordered 45 A380s, and everyone was saying, oh, you know, this big aeroplane, all those people, you're going to have nurses on board. And some of the statistics that I showed you earlier, we used that to say, no, we don't need, because basically if you had a nurse on board, it might be 1 in every 100 flights that they're actually utilising their skills. So here's the stats. So the likelihood of actual involvement. So on an A380, using the stats we talked about earlier, any in-flight medical incident, about 1 in every 20 to 72 A380 flights, because there's a lot more passengers on board, obviously. And then something warranting a MedLink call is basically 1 in every 300 or 277 flights, and diversions 1 in 2,377 flights. So really the need for medical people dedicated on board is pretty silly. Some airlines, or one airline in particular, has also got a system where they train doctors to be volunteers, and they get them on their books and they carry a card, and if they travel and agree to volunteer, they get an upgrade. But again, you could teach a whole bunch of docs, hundreds of doctors, but the likelihood of that doctor being on one of those flights when that happens is actually very, very low. So we don't really subscribe to that model, although I'm sure it'd be very popular in this room. But you can't drink, so... and sort of the statistics, we're at the top end. As I said, we're around the 85% mark, but there are numbers as low as 40. In the US, it tends to be much lower. Litigious society, they're very shy, so to speak. And of course, you need to consider your competence. Is it something you're competent to manage? Particularly the recency in emergencies. Fitness, so alcohol. Is it, you know, the fourth sector and you flight back to Brazil and you've just been going for 36 hours and you're actually a zombie? And not that our flights would make you feel that way. And obviously the willingness or concern reliability. So we call them MQVs, medically qualified volunteers. I alluded to, in the questions earlier, I alluded to some of the statistics that are out there, or some of the literature that's out there. So just flicking through this, what you can see that we get pretty good in-flight diagnoses are in close agreement with hospital discharge diagnosis. So, and people generally got better in-flight, and saying the medical care delivery is generally well managed. No significant difference between the improvement and the presence or absence of a physician on board. So people get better despite doctors or because of doctors, I'm not sure. You know, I suppose if they survive the first little while, it's likely they're going to survive the flight. So this was an American study. 40% of the time, they were associated with the highest diversion rates. This is after, even for controlling for the seriousness of the event, involvement of the physician ended up in a higher diversion rate than if there was no doctor on board. And basically, oxygen supportive care and close monitoring is the most important thing. And this was one of the studies using the in-flight telemedicine service, and they found that where the expert medical advice was available, the in-flight death rate was lower, but the diversion rates stayed the same. And Delaunay, on the other hand, when a physician participated in the decision to divert, the admission rate was 49% versus 15%. So that's a positive indictment of the involvement of the doctor. So how does it work? Cabin crew get alerted there's a medical emergency on board. They document in the voyage report what's happening. They request the captain to contact Medair, so the first port of call, unless it's a very serious event. If it's a very serious event, they'll quite often put the PA for a doctor out first because they know they're going to need hands-on. But otherwise, they'll contact Medair first, and Medair will advise them yes or no to call for a medically qualified volunteer. Medair will, it says direct the onboard physician. That's not quite the way it normally works. See, it's the other way around, or there's a debate or a disagreement. But they'll also indemnify the physician as well. They advise that you're indemnified for this volunteer activity. So that's one of our policies, that we do indemnify people. And then obviously the decision to divert, we talked about earlier, discuss it with Medair, yourself, but the captain has the ultimate decision. They can still say, no, we're not diverting, or we're not going there. I'm not satisfied with the operational risk. And our recommendations to volunteers is if there's something happens pre-embarkation, refer to the ground services. They're there. Help if you absolutely need to. In-flight, only intervene if you're competent, you're in full capacity to act. You are requested by the cabin crew or Medair, so not necessarily foisting yourself upon it, but sometimes it is appropriate. We had an event which was being badly managed. It's the first time I've seen it in the few years I've been with QANTAS, where someone who's basically massively affected by alcohol, was obstructing their airway and was being managed in a seated position, and the airway was compromised. And a doctor stepped in and intervened, and very appropriately. So, you know, where it says they're requested by, obviously, unless you see something like that occurring. If at all possible, some qualification evidence. Document. Quite often it's the last thing you feel like doing, but for your own protection. And also, we talked on this table about the recognition for volunteering. We'll talk about that in a minute. It's important to document, most importantly, your contact details as well. And then there's also worth considering advising your medical indemnity insurance. We've not seen any issues within Australia, certainly from an in-flight perspective, and the discussion at this table was there appears to be no real evidence, even in community volunteering, that anyone in Australia is really being successfully sued unless they've been willfully negligent, or stepped right outside their scope of practice. So we think the risk is very, very low. And when we talk to the insurance companies, we say if you had a guy that was volunteering, every week he's travelling backwards and forwards, would it impact the premium? They said we've never seen a claim, so we would only adjust premiums if we ever have a claim, and then we'll look at it, and the actuaries will take a look. So we don't think it's a very high risk. The US have a specific piece of legislation, the Aviation Medical Assistance Act, and it actually says the airlines and individuals, that's including doctors, are not liable unless gross negligence or willful misconduct. So we think the legal risk is sometimes a bit overblown, and it doesn't appear to be a significant issue. Recognition, we do have a system of recognition. The way it's all a bit, you can't read that, but essentially the message here is that sort of green, yellow and red, we code events. We actually code them. The pharmacist who does the kits goes through and looks at what was used, how long did the emergency last, what was the impact to the flight, did someone save a diversion, did they save a life, how much of that doctor's journey was disrupted, were they on their honeymoon and they just bought, business class seats and ready to have their first glass of Dom Perignon, and then this happened and they spent the entire flight sitting next to this patient, holding their hand and nursing them through, even if it wasn't a very serious situation. So we'll basically assess the impact and the value of the involvement, or was it just a 5-minute piece of advice? And the recognition will be adjusted to that. Sometimes the recognition will be immediate, so you might get moved up the front, or you might get a bottle of champagne or something like that. But for the more significant events, we'll usually do something afterwards, usually including a letter of thanks, and then something else: points, rewards, certificates for dinner, go out for dinner, upgrade for your next flight, sometimes refund the cost of your flight that you've just had, depending on the seriousness of the event itself. So we do try and be exhaustive, but if we don't have the documentation, or it doesn't get reported, or it doesn't get to us for some reason, sometimes you won't be recognised, and I'm sure you've heard stories of people that haven't been recognised. So I'm always happy to hear about that, and I haven't got my email address up there, but I'm happy to stick it up at the end. Kits. So we haven't got time to go exhaustively into the contents, but importantly, so this is kind of this is a Jetstar one as an example. We're trying to improve the ergonomics of the kit, so we're trying to colour code it, we're trying to increase the size of the font. You're quite often dealing with an emergency in the dark, in the middle, down, sitting in an aisle, you haven't got your glasses, whatever. So it can be quite challenging. So we're trying to improve the ergonomics, and we're going through a current review at the moment. We're also trying to group. So this is what we've been doing the last couple of years. Previously it was a big bag with stuff just piled in there, the best way it fit. So obviously, we're going to learn the lessons from other types of kit, and we're trying to code it functionally and make sure that there is clear guidance on how to use it. There are minimum standards. We talked about earlier, ICAO and the Aerospace Medicine Association. CASA has very little, but we all exceed those minimum requirements anyway. And what we do is we have a quarterly meeting where we review all the kit contents. We look at all the reports that we've received, the complaints. There's not enough IV fluid. Why haven't you guys got whatever in there? And some of those complaints do come from this group. This group wants sort of ICU-like conditions on board, and we just can't do it. We are constrained by space, by weight, and by shelf life, and by cost as well. So there are some things that we're not going to put on board. We don't want oximeters on board because we find that oximeters are actually just confuse the matters. You're much better off managing it clinically because oximeters are either be reading normally and giving a false sense of security, or they'll be reading low and we'll be diverting the aeroplane even though it's just a normal physiological response to the aviation environment. So we're not going to put portable oximeters on board. We're not going to put 6 bags of fluid on board, because if somebody needs that much fluid, we're going to divert the airplane. We're not going to try and give them fluid and keep them going for an 8-hour flight. So those are the sorts of complaints that we get. And the other ones that we don't have something to hang the IV on. So there's coat hangers, right? There are coat hangers in the cupboard. That's what we recommend is used.
Do you have an LMA?
We do have LMA, yeah, we do, yeah. So we also have a guide in there, and as I alluded to earlier, so we've got this sort of ready-to-use kind of guide, and we're putting this on the iPad, which is we're in sort of beta version at the moment, and it's much better because it's trying to flick through something where you can just tap and go to the relevant section. And each of these takes you through the management of those conditions and also what we've got on board and how we recommend you manage the situation. And some of the ones that we just, really pay off are things like urinary retention. And, we save diversions because we've got, Foley's catheter on board. You did that? Oh, thank you. Thank you.
Did you get the upgrade?
Speak to me afterwards. It was on Virgin, right? As I said, we're not going to go through all the stuff in detail. This is just, I'm just going to flash through content. So we've got, the intravenous stuff, the IV drugs, bits and pieces, ring cutters, scissors, all sorts of things. And all the stuff in there is because it's been driven by what we've seen, what we've experienced on board. We don't have stuff that happens once in a blue moon. We have stuff that happens regularly. Oral medications, urinary retention kit, we talked about, the respiratory equipment, and paediatric nebulizers, etc., etc. So we pack a lot into that medical kit, and we spend ages when we say, okay, we want to put something new in. We go, oh my God, what are we going to take out, or where are we going to move this? Because trying to fit it all into this bag and then fit that bag in the overhead locker where it fits, or in the dog box where it goes, is always an absolute logistic nightmare. So every time we put something new in, we try and take something out, if at all possible. And every time the ARC guidelines change or something like that, we'll adjust our medications. At the moment, some of the things we're looking at is trying to move towards wafers rather than IV, Dansetron and things like that, Lanzapine. Intranasal, something we're also looking at. So we're trying to avoid putting up an IV if we don't have to. So we're looking at those sorts of issues. AEDs, we're in the process of transitioning to the FR3 as our new AED. One of the benefits, as well as having a paediatric mode, is that it's got an ECG tracing, which our current defibrillator does not. There are also ECG leads that are available for the FR3 as well, and I'll talk about ECG in a minute. As I said earlier, I think we've kind of covered this. We get 20 to 30% shock indicated. The save rate's only 25 to 30% in the air, and we do have higher rates in our terminals for those reasons I talked about earlier, the orthostatic hypertension, the fact that someone's quite often found in the dark after 4 or 5 hours of being unresponsive and nobody noticed. And then some of the other stuff, just some stuff that we're looking at the moment, just out of interest. So in the medical kits, I talked about misoprostol earlier. Wafers just talked about. IV fluid, we are getting a lot of pushback to put more on board, and we're not putting more on board, so we've made that decision. Pulse oximetry, I talked about. We're not putting those on board either. And some sort of interesting travel clearance issues, like people with halo braces, how early can they travel? You've got turbulence, heavy landings. And what else might be of interest or a challenge from a CASA perspective, someone with a halo brace? Can anyone think what might be a...
Security screening?
No, that is a potential, but it's manageable. Something else with onboard emergency equipment. Life jackets. Can't get the life jacket over their heads. So CASA's so this is an issue, right? So
it's really got to be you break your neck and the plane.
Exactly. It wasn't your day, right? And so we're literally having to advise them, if you want a life jacket, you'll have to BYO kind of the vest style life jacket that you use water skiing. Some other interesting things. So tracheostomy is an interesting one at the moment because we are asked the question, if there's a decompression, will the Dixie cups, the drop-down oxygen, will that give sufficient oxygenation for a trachea patient? And we think the answer is probably no, to be honest, because if you ever try and sort of scrunch one of those things around, it just doesn't work. And in terms of the reservoir bag, it's designed to work that way. So we think probably the answer is no. We thought about, well, do they chop off the, chop off the mask and just put the inlets, there? That still probably wouldn't be high enough flow rate because you've got no form of reservoir. So they probably need to use, one of these types of adapters if they really want to be covered for a rapid decompression, which are extremely rare again, but do actually happen. So we're actually looking at maybe trying to find someone that could do a study to actually analyse this issue. So it's just a very, minutiae, but it's the sort of thing that we get asked about. Radioactive iodide treatment. So we've been looking at that issue and when people can travel after being given 131 iodide. So they're pretty radioactive for some time afterwards. They've got to avoid where they pee and all that sort of stuff, and they've got to avoid kids and pregnant women for some time. So we've done an analysis and worked with PANSA, the radiation protection people, about how soon afterwards someone can travel, depending on whether it was cancer or thyroiditis and what treatment they had. In terms of travelling afterwards. And again, it's the regional to metropolitan for your treatment, and then you want to get home. You don't want to spend a week in a hotel. So that's one of the challenges, particularly in WA and Queensland, where they're very regionalised. And then, some gas issues. Charlie Teo wants his patients to fly the day after the craniotomy, and we ask for a screening MRI and make sure there's no air, trapped air. Same with eye surgery and the gas. There are a couple of types of gas. One lasts 2 weeks, one lasts 6 weeks. And so if they fly with a significant gas bubble, there is a risk of some permanent vision loss as well. And then things like this bulle. Is a bulle there? Can I travel? What if there's a rapid decompression? I've got a 4 or 5 centimetre bulle. Will it burst and will I die from the bulle rupturing? All those sorts of just interesting minutiae that come across our desk. The use of oxygen in MIs. Obviously there's a bit of controversy about that in your spheres of life. We think on board the aeroplane, we're already in a hypoxic environment. Probably oxygen's a good thing in that environment. So our protocols are sticking with oxygen for the moment. We talked about agitated patients a little bit earlier and at this table. So, whether or not to add something else into the potential cocktail that sometimes people have got on board, alcohol, drugs and other issues, and then whether we sedate them as well or they're managed as a security issue rather than a medical issue. So there's some ongoing debate around that at the moment. People who are smuggling drugs and have massive narcotic overdoses, we haven't got enough Narcan in the kit to manage anything, of a very serious nature. We do have enough in there to reverse what we've given, but certainly not enough to manage that sort of thing. And then management of chest pain, which I'm going to touch on as pretty much the last kind of thing. So talked a bit about chest pain earlier and the fact that cardiac causes are around 45 to 50% of our diversion rate. And of the preventable diversions, when we look in retrospect, your strokes and seizures, and seizures are generally, we don't divert for one seizure, we divert for status epilepticus or repeated seizures, and they're justified. Your stroke's justified. It's it's time to treatment that's really important there. And obviously STEMIs are very much a justified diversion as well. But a lot of them turn out to be non-cardiac chest pain. And we currently don't have ECG on board, and very few airlines have ECG on board the aircraft, which kind of sounds a little bit, why wouldn't you? But it's been resisted for a long time for various reasons. So we're looking at this at the moment. And if we looked at a retrospective the last 20 cases, and we analysed each of the cases. These were the medical qualified volunteer involvements, so 15 docs, 1 nurse. We had 17 international, 3 domestic, and these were the fleets they were on. And we categorised them as to whether an ECG was indicated or not, useful or no change, or useful with a change in the management expected. We found that in 50% of our cases, the ECG may have made a difference to the outcome, and it may have been improved diagnosis. So quite often there was a misdiagnosis, particularly arrhythmias. We have had diversions for very benign arrhythmias, and quite often there's been a syncope and then there's a pre-existing benign arrhythmia, and a doc on board makes the call that says this must be sick sinus syndrome and we've got to divert the aircraft. Potential diversion avoidance. So we've got the ones I talked about earlier: chest pain, land, non-cardiac, get back on the same flight. Lastly, we may also have in situations where we've had a death on board or a bad outcome on board where it was not diagnosed as a STEMI, and in fact it was a STEMI. So we believe for these reasons that ECG will be valuable for us. So we're looking at options at the moment. And really have 3 options that we're analysing. There's this device, which is the Tempus IC device. Some of you may have seen the Tempus Pro, which is their version of the sort of full-blown ICU monitor. It's used in a lot of retrieval areas, particularly in the US. So this is the non-expert user. That thing there, that harness there, is the ECG strap. So it just basically goes around the chest. It gets pulled on, all those buttons. All the 12 leads are all rolled in nicely into one lead, so you don't have the spaghetti wire. I'd like to use it as for my standard ECG, let alone for in flight. And it's got oximetry, capnometry, temperature, glucometer, obviously blood pressure. I think that's probably about it. And it's got video and audio. And that plugs into the telephone jack in the seat and beams the telemetry down to Med-Air in real time, so that they're actually looking at the BP and the ECG and everything in real time. And they can drive remotely using this console here. They can drive remotely. They say, I want to take a blood pressure in Phoenix, and they press a button, and up on the aeroplane, the cuff inflates, and they can take a blood pressure. And they can also see the video or the still image, which the cabin crew's got on their little armband, and they take a picture and it goes down to Med-Air. And quite often that's useful because they look and they say, well, the passenger's not on oxygen, or the person's obese, or they're not lying flat, or something else from a still image. The video is just too distracting. We don't use the video. The other option, I talked about the FR3, so we've got ECG leads there. The connectivity and trying to you've got to pull the SD card out of there and then plug it into a laptop, and it's very, very fiddly. And we don't yet have FR3s across our fleet. But that's an option. And then the other option, which we're probably looking at our preferred option at the moment, is this. This one is one version of many of these new devices, which are kind of handheld ECG machines, combined with this glove, which is you put your hand inside the glove. I don't know if any of you've seen it. You peel off the adhesive and you put the glove across the chest, and it's got all of the 12 leads embedded into the glove. That connects to this little handheld device. You press that button, and it takes the ECG and sends it to whatever your iPad or your iPhone, and then gets sent down to the ground. So we think this is this thing's this is about $600. This is about $30-40 for each of these. So this is a really cheap option. And at the end of the day, whilst this has got all the bells and whistles, it's actually the ECG that's probably going to make the difference. And we've got a cuff on board. We can take a blood pressure. If we wanted to, we could put an oximeter on board. We don't want to. We really want an ECG. We want to see whether there's a STEMI or not. So that's the current thing that we're looking at. So that brings us to the end of the talk. I guess a few sort of conclusions there. Serious in-flight medical incidents occur uncommonly, diversions are rare, and deaths are exceedingly rare. Screening of passengers pre-flight appears effective in reducing the serious events. When needed, the medical care is effective and improves outcome, particularly when crew are trained appropriately. Improved diagnostic accuracy can be achieved via the use of ground-based telemetry support and appropriately qualified medical volunteers. Medical volunteers don't appear to be at medical legal risk and are generally indemnified. Recognition is important. I'm sure you would all agree with that. And then continuous review of the medicines and the medical equipment is required to ensure currency, meet our medical legal requirements. And then lastly, the use of data telemetry is promising, and there's some evidence that onboard ECG may improve both medical and operational outcomes. So that brings me to the end of my talk, and thank you for your time.
Well, thanks, Ian. That was a fascinating talk. Thank you so much. And perhaps just to start off the questions time, I just want to ask you, it sounds like there's a lot of potential scope for good research to be done in this area.
Massive amounts, yeah.
We've got a number of trainees, doing intensive care medicine training who are looking for research projects. So perhaps I can just encourage people out there that might be interested in this field to get in contact.
Most definitely, yeah, most definitely. We'd love that sort of arrangement. We've got lots of data and very little time, so which is quite often the case. So sort of industry, academia partnerships are great ways to do some research, and we've got lots of research questions that's sitting on the shelf ready to go. We just don't have the grunt to do it at the moment. So certainly, if you do have anyone interested in that sort of thing, very happy to work with them, provide them the data, and then co-publish or whatever the outcome might be. So, yeah.
Fantastic. Any questions from the audience?
And also any suggestions on medical kit contents, any revolutionary stuff that's happening in your space, any new equipment, any new gadgets and toys that might be. We'd love to hear about them as well. Yeah.
I mean, intensivists, they've got a lot of skills that are like really great in intensive care unit, but I mean, really, on a plane, what's the best thing you can do as a doctor? I mean, clearly you can't do ECMO and dialysis and all that sort of stuff.
No,
what's the best thing we can do?
Well, it's first principles, right? So it's just back to first principles. The best thing you can do is first principle medicine. Try and first supportive care, ABCs, and from there formulate a provisional diagnosis, look at what's in the kit, and don't do any harm. Don't start diving in, because we do find that, most people do well despite us, or, generally rather than because of us. And quite often we're filling the time till we divert the aeroplane. But it's supportive therapy. It's, as it said in the talk, it's oxygen, sometimes fluid, basic drugs. Supportive therapy is really, what we find. And I think that's sometimes that overthinking is when we see people get into trouble. Yeah.
Do you think there might be a role for, say, some of the newer point of care testing like
troponins? Yeah. I think certainly we've been looking at it. I think it's the next piece after the ECG, right? So, I think that at the moment probably the biggest difference we can make is to get a good, accurate 12-lead ECG and get it to the ground, hopefully, or if not, one of the 85% on-board doctors. Again, we've got those issues around interpretation of ECGs, and there is a risk that the person with the non-cardiac sounding chest pain, the ECG then shows, I don't know, left bundle branch, and we get an inappropriate diversion based on an interpretation issue, which is why we'd prefer the ECG to go to Medlink or to, if there's a critical care doc, face and fans car, J. Fickham type person on board, then brilliant, Yes. Rural generalist as well, forgot to put them on the list. Yeah, stethoscope. Yeah, stethoscope's pretty useless on board the aeroplane. I failed to mention that as one of our commonest complaints. Why do you have such a crappy stethoscope on board? And the answer is because it's there to identify who the doctor is. That's the main purpose of the stethoscope, hanging around their neck. Because you cannot hear a thing on board the aircraft. It's sometimes useful on the ground, but a stethoscope, and we've trialled Littman's through to, we have a $50 one on there. It's it's not the crappiest one, but it's certainly not a super one. And the reason is we trialled them all; it made no difference. But we do have BP cuffs, that sort of basic thermometers, glucometers, those sorts of basic things are on board.
Up the back there, yeah.
Have you considered or trialled the really mini echo type things?
No, we haven't got into that space. But I think, echoes, I think ultrasound in general.
Yeah, I mean, like the mini ultrasound things,
Yeah,
pneumothorax, not pneumothorax.
Yeah, I think ultrasound, certainly in my RFDS days, use of ultrasound, in the remote settings is becoming widespread. And I think as it becomes embedded in more as a core skill of diagnosticians, I think it probably eventually may have a place. But at the moment, we wouldn't have enough people competent to use it to make it worthwhile. And I think it might end up just confusing things more than it would help at the moment.
As a junior doctor, we're often asked by patients or relatives to write a note to excuse them from upcoming travel. I had one rejected the other week, and I was wondering what was actually improved.
So you were saying that they missed their flight because they had a...
No, it was an upcoming flight.
Right.
And they were just given the standard pay a fee to reschedule.
Yeah, okay. I think if it's rejected because of the conditions of the sale as opposed to whether the medical was justified or not. So, so there are some tickets that there's super cheap ones that says even if your mum's dying, you don't get refunded. I think it's not a medical question, so...
I'm just wondering what type of evidence of medical qualification do the crew check before?
They would just generally, they won't ask for evidence, they would just have a short interview with the person and they formulate a view. So there's no, because there isn't an official, I don't have an official ID card to say I'm a APRA registered doctor in Australia. I've got a membership of this or that or an AMA card or, whatever, but there isn't any official... and again, the discussion at this table is when we get to the point, now that we've got internet on board, you can maybe do a quick search of the APRA register, at least for Australian registered doctors. But in the meantime, hopefully someone's managing the emergency.
Do they have any current claims against them?
So it's just a judgment call, about competence, inebriation, and then qualifications. Like, if they get someone coming up who's probably maybe not the right person, they might look for somebody else.
Yeah, your ARPA registration, when it comes in the mail now, there is actually a little card you can push out of the piece of paper, and you can carry that with you.
That's true.
If you so desire.
With your frequent flyer number.
Everyone hold them up. Yeah, right. Yeah, now hold up your frequent flyer card.
Actually, it's an interesting question. Say there's a discordance between what the on-board medical doctor thinks, whether they be an intern or an intensivist, and the ground-based crew in the basement in America.
Phoenix, yeah.
Does the crew have any instruction as to who to listen to, and if there is a discordance, are we still indemnified?
The captain will make the call, and there's no official line on it, but the captain will make the call. They trust Medair. Medair generally are sound, but Medair is not infallible, and Medair are not on the aeroplane. Generally speaking, if the medically qualified volunteer appears to be credible, they'll take that person's view. So quite often we get meddling did not recommend diversion. Diversion occurred because the doctor on board felt it was necessary. So they normally win out whoever's on the scene.
Alcohol must be a funny question, because I guess that an intensivist with one glass of wine in him or her would probably be better than Joe Blogs with nothing. What are your thoughts on that?
Yeah, there's no breathalyzer on board, so we don't. Do you feel? How do you feel? Do you feel comfortable in proceeding? And the cabin crew, if you say yes and they think no, it'll be no. But not the other way around.
You say, okay, another glass of Dom Perignon, thank you.
Yeah, that's right. Yeah, hold the IV in one hand, but they're pretty good about it, and they realise that as you said, just one glass. There's no official legal limit as far as I'm aware. So. Any other questions?
Any other questions? Well, thank you very much. Yeah, that's
welcome. Thanks for having me.
Absolutely fantastic. So everyone, please.
Thanks for listening. For more great talks from the Intensive Care Network, go to intensivecarenetwork.com.